Good afternoon, everybody. Thank you so much for joining us for this wonderful event this evening. I am joined by Dr. Abraham Zavala, who is from Clínica Tambre, who are based in Madrid, and recently enough have just opened a new unit in Alicante in the last few weeks, which is wonderful to hear. We're going to be talking about a vital topic, and I know one that so many of you are going to be interested in, which is improving your endometrial receptivity and how to optimize your odds of having proper success with IVF. This is something that I think is vastly under-acknowledged, and I'm sure you'll agree, Dr. Abraham, because so often in the world of fertility struggles, all we hear about is age and egg quality, which is fine, but it's not acknowledging the other part of the equation, which is the internal environment. And that's something that needs to change because, as you well know, you can have the most perfect embryo in the world. It can be euploid embryo, donor egg embryo. But if you haven't got the internal environment right, you're going to struggle and you're not likely to have pregnancy success. So that's why we need to talk about this in more detail. So before we dive into kind of the complexity of this topic, it probably would make sense to start with a brief overview of what we're discussing when we talk about endometrial receptivity, like just in basic layman's terms for people, what do we mean when we talk about that?
Well, first of all, thank you for that introduction, Jessica. I am very happy to be here. And, as we were talking about before starting this webinar, we are very glad to now have this second clinic in southeastern Spain, in the city of Alicante, city with a beach, just in case that might interest anyone. And yeah, we're very happy because we're actually opening our doors and we're very, very excited about this. And speaking of endometrial receptivity, yes, this has been considered a type of last frontier in assisted reproduction because, it's shrouded in so much mystery about how it works. And I think part of this is because of the endometrial tissue itself. If we were to, compare it to the ovaries or, the egg cells or the sperm cells, it's different in the sense that it's very dynamic. So it's going to change with each period, and that's why it's sometimes hard to gauge at how to approach it. So if we begin with a brief introduction of what the endometrium is, we have to think as the ovaries and the uterus as going through two separate processes in parallel. So there's going to be the ovarian cycle happening at the same time as the endometrial cycle. Okay, so what's going to happen is that along the 28 days of a standard ovarian cycle, there's going to be a follicle that is going to be stimulated and it's going to start producing estrogen. Now, this estrogen is going to act as a stimulus for the inner cavity of the uterus, what we call the endometrium or the lining. Okay, so this estrogen is going to cause the endometrium to thicken or to grow, but it's not going to be receptive just yet. The endometrium is going to become receptive when that follicle ovulates, when it releases the egg inside of the follicle, and that follicle is going to turn into something called a corpus luteum or a yellow body. And instead of producing estrogen, it's going to start producing progesterone. And once enough progesterone is produced, it's going to make that endometrium or that lining, it's going to help it acquire its receptivity. So as you can tell from this explanation, we're going to have a period in which that lining is receptive, when it can bond or attach to that embryo that is placed in the lining.
So there's a really specific time frame. I think that's the key thing to note. It's like a flower coming into bloom at a particular time. That's what we have to capture. And I think what you're alluding to there, well, obviously that was talking about, sort of a non-assisted picture treatment cycle. Of course, if someone's going for a frozen embryo transfer, I'm sure they're familiar with the progesterone that they're given because you don't have the corpus luteum necessarily. So that's just on the kind of the hormone and the sort of growth and preparation and decidulation of the lining phase. But I think what people sometimes aren't fully understanding of, because they're not taught about this, none of us are, is
Yeah.
the overall complexity. Like if we look deeper into that, what's going on in that endometrium, apart from all the cellular change, like there is a whole smorgasbord going on in terms of the amount of change with the immune markers and blood flow and nutrients coming and pro and anti-inflammatory markers. So I think, I suppose, what I want people to understand before we go into each of the issues that would affect receptivity is just the sheer level of complexity that there is to it.
Yeah.
It's things
And
happening at once.
I think that this is going to be a type of onion that we're going to have to go through each layer, right? And I think that we just kind of peeled off the initial layer, right?
Yes.
The very basic way in which the lining works. That's why most endometrial preparation protocols are going to be just that: estrogen for a while, and then we'll add progesterone, right? But you're right. With progesterone, we have many changes that happen in the endometrium. So with progesterone, we're going to have different glands that are going to start forming within the endometrial tissue, which is one of the basic differences between a lining that's only been exposed to estrogen and a lining that has had progesterone. The gland formation. Also, the blood vessels are going to finish proliferating within the endometrial tissue. And also, there are certain types of white cells that are going to rush to the place where that embryo is trying to attach to, and the crosstalk process is going to begin between the embryo and the endometrial lining. Okay, so there are lots of adhesion molecules. There are lots of molecules called integrins, different types of white cells that are going to take part in this crosstalk. And also, one of the concepts that has changed over time is we used to view the endometrial cavity as a sterile compartment, right? We used to think that there wasn't anything there. Now we know that can't be further from the truth, in the sense that there is a microbiome. Okay, a microbiome that is composed of mainly good bacteria. Okay, primarily lactobacilli, right? But also there could be the presence or the proliferation of what, as a gross oversimplification, I'll just call bad bacteria. Bad bacteria that may cause silent infections, inflammatory processes that may interfere with the implantation process of the embryo.
So there's, exactly as you said, a multitude of things cross-talking with each other. So yeah. I think in order to try and break down this complexity for people, because anybody hearing this might go, oh my goodness, right. So there's 10 million things I have to think of. Where do I start? So if we break it down maybe into the different categories, so perhaps the one that might be more familiar to people, especially in the initial stages of investigations, would be more of the anatomical physical issues that would affect the endometrium. So perhaps if we start with that area, with investigations and things that might go awry that need to be addressed, such as, polyps, fibroids, any issues with adenomyosis, all that kind of thing, or even thin endometrial lining, because that's a more physical issue. And if we start there, we can progress then into the more complex stuff.
Yeah. And, before we kind of go into these issues that may arise during fertility treatments or when diagnosing infertility, I'd like to make a small disclaimer, and that is that this is a huge gray area, okay? And what I mean by gray area is that many of these therapies or of these theories have been proven in some studies, and there could be evidence that backs them up in certain populations and specific conditions. And then most of these also have multiple studies that either disprove them or can't find enough evidence to support them. Okay, but also one of the things that we need to talk about is that this endometrial receptivity is most of the time is not your primary suspect into what may be going wrong. The most important factor is often outside of the endometrial cavity and has everything to do with the embryo and whether that embryo is genetically competent or not. So that's one of the kind of the one of the premises that we need to talk about first. But it's true that there can be many conditions that affect the endometrial environment. And as you said, one of the first, I think that starting with the anatomical issues that may arise is a good way to kind of go from the more general to the more specific when talking about the endometrial lining. So we know that, when the uterus is developed during fetal life, there are certain anatomical issues that may arise or anatomical abnormalities. Okay, and we know that there is one specific one that can be related to adverse fertility outcomes, and that is something called a uterine septum. Okay, that's when the uterus is forming, there can be an inner wall that doesn't get reabsorbed as it should, and it stays. And that can often be a problem for the embryo's implantation or for a healthy pregnancy development. Okay, so that's one of the things that we need to look for through when doing the initial fertility workup. Also, there may be other issues that may arise later on, such as endometrial polyps, such as fibroids that may affect the cavity. And as I said, none of these are going to be 100% the reason why pregnancy is not happening. But we know that removing polyps or removing fibroids that are inside the cavity gives us a better outcome in fertility than just letting them be there.
So that's just important to clarify for someone. So if we're talking about uterine anomalies, so we're talking about the shape of the uterus, and obviously if something's septate, so it's also got that division that can make it difficult and more likely for there to be implantation issues or miscarriage. So in terms of for somebody who's like, oh, I might have a septate uterus, or I might have uterine polyps or fibroids, for them, what is their next step? Because I know for anybody watching this, the question is always going to be, well, what is it and what can I do about it? So in many cases, surgery would be feasible, assuming it was deemed necessary.
Yeah. So one of the approaches that is readily available is, especially recently, is the 3D ultrasound scan. Okay, so the 3D ultrasound scan is a great way to see the shape of the cavity, and sometimes we're able to also notice subtle abnormalities inside the cavity, such as polyps, such as fibroids. Also, by placing some fluid inside of the cavity, we're able to see some of these outlines through the ultrasound scan. Okay. But one of the more sure ways in which we can approach this is through a hysteroscopy. Hysteroscopy used to be a procedure that we only did inside an operating theater and under anesthesia. But now we know that we can do what we call office hysteroscopies or diagnostic hysteroscopies without anesthesia in a tolerable way. And it provides a way in which we can see the endometrial cavity firsthand through a hysteroscope, which is basically a camera that we can introduce into the uterus and take a look at the inner cavity.
Transvaginally, of course, it's not
Yes.
laparoscopy, just so everyone's aware.
Yeah.
Yeah. So when you go in with a hysteroscopy, so you can take that closer look at the internal environment. Of course, shall we say, diagnostic hysteroscopy, if you're trying to confirm ultrasound findings, can turn surgical if needs be, if it's to remove a polyp or something like that. And in most cases, well, certainly that I've seen, I'm sure you've add to this, I would see that typically a uterine polyp or polyps they'd recommend to remove. Fibroids kind of depends on the size and the location and all that, whether they'd want to touch it or not, because you don't want to risk the structural integrity of the uterus. But essentially what we're talking about at the moment is anything that would affect that kind of topography. So in other words, we're still talking about stuff that you can see, as opposed to stuff that's on the molecular level, which is the toughest. So that definitely is something that people should have ruled out if they're looking at issues that would affect receptivity. And would you lump into that bucket the issues with the lining thickness, or would you put that elsewhere?
Well, so you're always looking for a probable cause, right? So there are a few reasons as to why an endometrium may not achieve a desired thickness, right? One of one of the reasons why that may happen may be due to the formation of scar tissue. Okay, something that we dubbed Asherman syndrome. Okay, this is something that we might suspect in patients that have had, for example, multiple endometrial procedures, such as multiple DNCs, for example, right? So that would be something that we could see with a hysteroscopy, and that we would be able to treat with that hysteroscopy. That's something that we can do in the same way that we could remove a polyp. Okay, and I just want to touch on fibroids, because I think that what you were saying was very important. So there are different types of fibroids, and we name these fibroids depending on the sites at which they're growing. Fibroids are uterine muscle cell tumors, benign. The great majority of these so-called tumors are benign, and we need to know that they're also very common. Many women go through fibroids. Reality is that most fibroids are not going to need treatment, right? Fibroids can develop inside the endometrial cavity, inside the uterine wall muscle, and essentially outside of the uterus, outside of that outside layer of the uterus. When talking about infertility, most fibroids that are going to affect the embryo's implantation process are going to develop inside of the cavity, or they're going to affect the cavity. And these are the fibroids that we sometimes need to treat.
Thank you so much for both clarifying that about the fibroids, because I think people think it's a numbers or size thing, but sometimes you can have one larger fibroid and it's not as much of a problem as lots of smaller ones that are all submucosal. So, and also the Asherman syndrome. Thank you for mentioning that, because you just reminded me of a client I'd had a number of years ago who had unfortunately been kind of medically gaslit at that time about the fact that post miscarriage and post DNC, so dilation and curettage, or like similar to ERPC, that she had big changes to her period. So if we're talking about Asherman syndrome, just to remind anyone watching that if you suddenly see post procedure, because that is the most common typical way that adhesions, if you suddenly see your period go AWOL, you know, like, and you're being told, oh, you're perimenopausal, which is what my client was told because she was 41. Just be really mindful of getting to somebody who actually knows what they're talking about when it comes to the internal environment and micro instrumentation surgery, who can properly address adhesions, because as I'm sure you've seen in your practice, it can make a dramatic difference to the odds of success. Like if you're talking about the embryo being able to implant, if you've got Asherman syndrome present, it is going to make things very difficult. And particularly in those devastating cases with multiple pregnancy losses and multiple procedures. They don't even realize that what's often then causing the higher risk of miscarriage is the fact that they've gone through more procedures. It's not necessarily chromosomal abnormality anymore. So again, I think the rule there is never make assumptions. Always make sure to get that properly checked out. And so when you were touching on Asherman's, I suppose that follows on into what we're discussing as well with lining thickness, and the sort of reasons for why that water wouldn't be thick enough, as it needs to reach that 7 millimeter minimum, preferably over 8. And I did note that on the Clínica Tambre website, it noted about some of the treatment modalities that you would have for that, and did also mention PRP. So I don't know if you wanted to share some more info on that, just for anybody who might be struggling, again, still with the anatomical side of things, like with the lining thickness.
Yeah, so PRP is platelet-rich plasma. Okay, and PRP has a number of uses in medicine. It's not something that we use exclusively in fertility. It's even used in aesthetics medicine. It's used in many different branches.
Vampire facials. That's how a lot of women go, oh yeah.
But so there's a difference when we talk about ovarian PRP, which has something that has been dubbed as ovarian rejuvenation. And then there's PRP for the endometrium. Okay, so as I said, platelet-rich plasma. Okay, and you might be wondering, what are platelets going to do to my lining or to the follicles in which they are injected into? So essentially, not much, right? But the thing is that when these platelets break down, they release growth factors. Those growth factors can help in cases of refractory endometriums that don't respond well to medication. So the treatment usually consists of acquiring your PRP. We take it from your blood sample. We isolate the platelets and concentrate them a lot more than they would usually be in normal blood. And then we infuse this PRP into the endometrial lining, usually about 3 or 4 applications during that endometrial preparation protocol. And this can sometimes help in the lining thickness. Now, why would we be so adamant about increasing the thickness? Well, because there are multiple studies that have seen that thicker linings are associated with better implantation and better pregnancy rates.
Just like planting a seed in soil. That's how I'd describe it to people. You kind of have that sort of minimum threshold, but just because it's minimum, in fact, I'm just thinking of a client I was speaking to this morning who had a rough outcome with a recent fertility treatment cycle. And she was telling me about the fact that her lining was really never getting above 6.4. And I was like, just because it's on record that a pregnancy has happened at some point in history with a lining thickness of, as low as like 5 or 4.5, I think was the lowest on record, doesn't mean it's optimal. So really make sure for people, just to push for optimal when you're going for a transfer.
Yeah, that's why we always have to, all these limits that we talk about, that we really need to put them into context. There are patients that are going to have a very hard time achieving a 7 or 8 millimeter lining. That's true, and we have to reduce our threshold in those types of contexts, or find a reason as to why we're not getting there. But when we talk about the endometrial thickness, I do think that 6 millimeters is really the bare minimum. But we ideally want this thickness to be above 7 millimeters.
Yeah, at least. So just because I think sometimes people are told a beautiful lining, gorgeous trilaminar appearance, but they're not necessarily being told about the thickness. So that's kind of on the physical anatomical side, right? So we're trying to break this up for you guys so that you can compartmentalize it, because I know it's a lot to absorb. Yeah. Then if we move a little bit deeper, areas that I would say I would often see being overlooked and are more easily overlooked because maybe assumptions are made about it, would be things like hormone balance, you know, and having things on point there when you are both trying to conceive non-assisted as well as assisted, but particularly even for fertility treatment. Again, thinking of a client who was, you know, going ahead with her fertility treatment cycle. It was a fresh cycle, but she hadn't really had much check of her thyroid, even though her thyroid had been a bit of an issue the year before. So maybe let's discuss some of the issues with hormones that could cause problems for someone in terms of their endometrial receptivity.
Okay, so when we talk about when we talk about, you know, preparing your lining, making sure that it's receptive, there are three very important hormones that we need to talk about. I will get to TSH, but I'm going to mention that one last because there's a lot to talk about. But I would like to talk about estrogen and progesterone. Okay, so you'll hear me say estrogen a lot, and just so we know, there are different types of estrogen. Okay, there are actually 4 types of estrogen that a woman would naturally produce across their lifetime. There's a certain estrogen that they produce before puberty. There's another type of estrogen, which is estradiol, which is actually one that we're going to focus on, that you'll produce throughout your fertility period. And then another type of estrogen that will be produced exclusively in pregnancy and then after menopause. Okay, so those are the 4 types of estrogen. Now, estradiol is very important because that's an estrogen that the follicle produces. In fact, 95% of a woman's circulating estradiol comes from the developing follicle during the cycle. Okay. Now, when we prepare a woman's lining, we do so with estrogen. So it's estradiol? No, it's a different type of estrogen. But we know that there's a certain threshold in which we want that estrogen level to act. Okay. So it's something that we don't usually measure, but it's a good idea to measure it because high levels of estrogen before an embryo transfer may not be ideal. Okay. Then a lot of patients are confused with why and when we measure progesterone, because most clinics will adopt a protocol in which we'll measure progesterone about a week before the embryo transfer, and then we'll measure it again a day before. Patients are always confused as to when we want progesterone to be low, when we want progesterone to be high. So, as I said, the endometrium will not become receptive until it's been exposed to progesterone, ideally to 120 hours or 5 days of progesterone. That's why we measure your progesterone levels a week before the transfer, because we want to be sure that that lining has not been exposed to progesterone. We want low progesterone levels, okay? And then a day before the embryo transfer, we'll measure it again after you've been on progesterone for about 3 to 4 days, because we want your lining to have very good levels of progesterone, above 10 nanograms per milliliter of progesterone.
Which is over 30 nanomoles for the European versus US, UK. Yeah.
So now talking about TSH. Okay, so TSH is a hormone that controls the thyroid activity. Okay, it controls the T3 and T4 hormones, which are the active thyroid hormones. Okay, now when your body senses that the thyroid levels are too high, it'll try to decrease your TSH levels so that those come down as well. Okay, but if your body senses that the T3 and T4 hormones are too low, it's going to try to increase your TSH level to try and increase those hormones. Okay, so when we think about doing a preparation protocol and the TSH levels are too high, that means, and it's kind of counterintuitive, that we may have a hypoactive thyroid. Okay, that's why it's called hypothyroidism. Okay, now the range in which we want your TSH levels to be in the general population is between 0.4 and, depending on the country and the lab, about 4.5. Okay? That's the range that we want. there are two populations in which we set different limits, and that's in pregnant women and women trying to get pregnant. Okay, in these populations, we're going to want the TSH level to be below 2.5. Okay, so if you get a TSH result that is, I don't know, 3.2, does that mean that you have hypothyroidism? No, not at all. But it means that for the purpose of achieving pregnancy, we may need to lower that TSH a little bit more, okay? Because we know that TSH levels above that 2.5 threshold may have adverse clinical outcomes in terms of pregnancy and fertility. There are a lot of caveats to this. So this is something that your doctor needs to go through with you, because there are a lot of things that we need to explain. It's not as simple as, above 2.5 we need to treat. But that's, again, it's a gross oversimplification of one of the things that we also need to take a look at.
100%. And that's why I just wanted to raise it, because I think sometimes people get lost in the cracks. They might have seen their GP, who, no disrespect to anyone's GP, but maybe they're just going by the standard ranges and not fully considering the impact on pregnancy. And then if they're going into the clinic, maybe the clinic thinks, oh, well, you had your bloods done before, so everything's fine. I think the devil's in the details, as we know. So it's just trying to help people to watch out for those gray areas. And exactly as you said, having that monitoring of the progesterone, which for many people, just so anyone who's watching is aware, it isn't automatically standard, as I'm sure you know, Dr. Abraham, in certain clinics that they would monitor that. I know of many people who've told me that it isn't checked, and they might just be given progesterone, but nobody actually monitors the levels and how they're responding. So thank you for highlighting that. It's so critically important. And so that's the hormone side of things. Hopefully we've categorized that well for people to get their heads around. The other areas, which we'll try our best to go into a little bit, because I can see there's plenty of questions here too to get through, but I think these are important to explain. Going back to something you said earlier, which is an important caveat and disclaimer to make, which is that it's absolutely true. There is a lot of mixed research in this field. I think one of those areas where there probably is quite a lot of mixed research is just about the window of implantation. Going back to that, flower in bloom analogy and the timing of when the embryo goes back in. So maybe we want to touch a little bit on that in terms of sort of the endometrial receptivity assays that might be done, and your thoughts on the utility of it, because from what I can tell from the literature, it seems to be of most benefit to those who really have had recurrent implantation failure.
Definitely. Okay, so first of all, does the window of implantation even exist? Well, yes, this is real, right? That does exist, and we know that implantation window comes about 6 to 7 days after the ovulation period, usually in a 28-day cycle. This would be around day 22 to day 24, 25 of that cycle. Now, what defines this window of implantation? Well, that's when the lining is exposed to progesterone, has developed a glandular system in that lining, and it's expressing certain molecules, certain adhesive molecules, certain integrins that make it ideal for that embryo to attach. Okay, so that's kind of the biological aspect of it. Now, the more theoretical and treatment aspect of it is that there may be women, some research says about 1 in 5, 1 in 6, that may have, quote unquote, a displaced window of implantation. Okay, that means that that lining isn't expressing those molecules, those glands, at the same time. Okay, there are different commercial kits that measure whether that lining is receptive after 5 days of progesterone. I'm not going to drop any names, but we all know the one that we're all thinking about, right? Yeah. So there have been different studies that have tried to prove whether it works or not. In fact, there was one large study that was recently done in the U.S. that was actually a clinical trial that would either transfer the embryo according to the result of that test, or it would transfer it on the day that it would normally transfer it, regardless of what the test said. Okay, and they didn't seem to find a significant improvement with the endometrial biopsy. So does that mean that the endometrial biopsy doesn't work? Well, we really can't say just yet. We do need a lot more research, because there are smaller independent studies that may show some benefit in the endometrial biopsy. What we do know is that this can't be applied to the general population as a whole. This is something that we really should reserve for women with what we call recurrent implantation failure, that have had multiple blastocysts or multiple chromosomically normal embryos transferred without having a successful pregnancy.
Yeah, it's important clarification area there, because it's not something that's your first line test. So anybody looking at this thinking, oh, I'm going to go do that. No, it really is reserved more for those tough cases, and understanding that, at the end of the day, with some of the research, they haven't necessarily found a difference in the live birth rate. So that's kind of what matters at the end of the day for people. So with the window of receptivity, just have that in mind when you're talking to anyone about it. So going a little bit further, there's a couple more areas I want to touch on. There's some complex stuff, which I don't know if we'll get into, but we'll try, because I do think it's important and can cause confusion for people. But if we're getting now to the nitty gritty areas where these aren't things that you can see with the naked eye, so we're getting into the areas of, microbial balance and infections. I think when talking about infections, certainly for many of the clients I've worked with, very often the assumption or confusion that is made is that you're sort of talking about standard STIs as opposed to all those insidious subclinical infections. So maybe let's touch on endometritis a bit, and what can go on in that sort of delicate interplay of the uterine microbiome.
Yeah. Okay. So anytime that you see a medical term that ends in itis, it's always going to mean that there's inflammation of whatever tissue it's trying to describe. And endometritis is not the exception. So endometritis means that there's an inflammatory process of the endometrial lining. Okay. Now, one of the reasons why this could happen is due to a microbial infection. So some type of bacteria that has overgrown and is causing more inflammation than usual. Okay, so this isn't something new in the sense that now there are commercial kits that can measure this and can tell you exactly which pathogen we have, and that certainly helps. But we used to do this a long time ago with staining of the endometrial biopsy and seeing whether there was a type of white cell response that basically gave us the same information. It didn't tell us which bacteria it was, but it did tell us that there was an inflammatory process going on. Now, I think it's so interesting what you were saying about how we often think that we're talking about STIs, because that's something that I thought myself. I thought that when there was an endometritis process going on, that it was either going to be due to chlamydia or gonorrhea, but often the bacteria that I get from the results are often things like streptococci. So something that you may not expect, but it is the same premise. So most of these endometritis tend to be silent infections, so you may not be aware that you have them. You're not going to see any type of specific flow during your period. You're probably not going to experience pain or anything abnormal, and you may still have this silent inflammatory process going on. Now, this inflammatory process is going to draw an immunological response from your body. This is where we get the plasma cells from. So plasma cells are going to rush to the site to try and take care of this infection. Now, plasma cells are not the ideal white cell that you want in your lining when you're trying to have the embryo attached to the endometrium. So that's why it's important to identify these cases of endometritis and try to treat them. Now, is this 100% proven and 100% fact that it creates an obstacle in the endometrial implantation? Again, gray area. Some studies show that women with recurrent implantation failure have a higher likelihood of having endometritis. And more interestingly, women with recurrent miscarriage have an even higher amount of endometritis compared to normal population.
Yeah, so spot on, because an analogy I sometimes try to use for people to help clear it in their heads, because we were talking there about the different types of bacteria. And so therefore you're talking about something pathogenic. So in other words, something that really shouldn't be there that could be causing inflammation. But we have two sides of the fence, because you've got the pathogens or the bacteria that really shouldn't be there, but then you've also got just the balance of the good bacteria. So using a garden analogy, it's kind of like, you don't want the really bad weeds, you want to get rid of those, but at the same time, we'd also like some roses in there too. So if we can just touch on that, comparison there of where someone might not actually have necessarily specific pathogens causing problems, if they have very low levels of the lactobacillus relative to the balance of other bacteria, that could still be an issue for implantation.
Yeah. So so a very important point. So we often, when we explain this, we often talk about good bacteria and bad bacteria, right? We really don't want bad bacteria, but we don't want no bacteria, right? That's not what we want. We want a good amount of good bacteria. We know that good bacteria may improve the chances of implantation, and it also helps because it keeps the bad bacteria. It doesn't really give them room to grow. So it's important to have those adequate levels of lactobacilli, which are considered good bacteria.
Yes, exactly. Just like the garden, if you've got all the lovely flowers growing, there's less space for the weeds. So it makes it easier for implantation. And so that's on the kind of the infection side, which obviously then if somebody finds something just in terms of action steps, they would probably be prescribed an antibiotic. And also something I wanted to clarify too, because I've seen this missed in some people's cases, is that it's not just about the woman and the uterine microbiome, that of course there could be cross-contamination going on if there's something going on in the semen. So just to make darn sure that you have both partners being assessed, and that, it's not a case of someone being given a broad spectrum antibiotic, but then you don't know if it's going to work for the infection, and then the other person isn't taking it, and then you can have problems. So a really comprehensive workup, I would say, would be advisable, certainly if you're trying to rule out the infections. And then, as much as we can fit in before we get to the questions, because I really want to get to everyone's questions, on the immune side, now it's wonderful the Clínica Tambre has that reproductive immunology unit, because the whole area of alloimmunity, I think we do need to touch on just a little bit. I know it's confusing for people, but it's so, so important. And in those tough cases, but then again, if we're talking about stroke, it seemed like the
yes, I did.
Okay, sorry.
My question one more time.
No problem. I was just talking about alloimmunity and the more, shall we say, complex cases, because I've definitely had some of them myself who needed to go down the path of doing the testing for testing and what you guys would do.
It's like the internet doesn't want us to talk about autoimmunity.
Yeah, it kind of is.
Right. when you're asking that question. So, you know, I did not hear your question, but I'm just going to talk about.
You can go for it. I'm sure you know what I'm getting at.
Yeah. So, so it does seem confusing, but I think that, you know, we can explain it in simple terms. Okay. So and again, this is something dynamic that changes depending on the specific time of the cycle. Okay. So we've seen that the white cell that is mainly in charge of the crosstalk between the embryo and allowing it to attach to the lining is a cell that has been wrongly named the natural killer cell, or the NK cell. Okay, we used to measure this in blood, but now we know that blood levels may not actually be giving us the full picture of what's going on, because now we're able to measure the UNK cells, or the uterine NK cells, and we know that these fluctuate along the endometrial cycle. Okay, so when we have the receptivity window, these NK cells are going to rush in to try and mediate the crosstalk between the embryo and the lining. Okay, so there are different types of NK cells that, for the purpose of this talk, we're going to say good NK cells and bad NK cells. And we want there to be more good NK cells than bad NK cells. Okay. Sometimes when we have too many NK cells or too many bad NK cells, that can have a negative impact on how that embryo attaches. Okay. And just really quickly, I'm going to touch on something called the HLA KIR, because that's something that I get asked a lot about. So basically, we're all going to have a certain HLA. Okay. So that means that the embryo is going to have a certain HLA based off the embryo's parents, basically.
The DNA coming through from the parents.
Yeah. The type of HLA that the parents have will give us a certain HLA profile to the embryo, and the embryo is going to, you know, have that HLA. Now, the NK cells are going to have a KIR receptor. Okay, there are different types of HLAs, and there are different types of KIR receptors. Okay, so this means that there are going to be different combinations of HLA and KIR. Okay, now we know that certain combinations may be better than others. Okay,
like a lock and key, and some of them don't fit as well as others.
Exactly. The immunologist at our clinic, Dr. Padura, would be very upset if I use the term compatibility, because it goes a lot further than that. But for the purpose of this webinar, let's just talk about there are ones that work a bit better than others. And, you know, certain combinations will be more predisposed to implantation failure, to miscarriage, and even certain complications during pregnancy, such as high blood pressure, called preeclampsia during pregnancy. So, you know, this is something that we may decide to look into, depending on the context of the specific situation in which the patients may be at.
And it's typically going to be in those tougher cases. I threw it in there at the end, but just because I find, you know, in situations where people are really at the end of their tether and they're thinking, is there anywhere else to go? Is there something I haven't checked for? Sometimes it's these kind of tests that can help you to understand why your body sort of might be rejecting the embryo because it's not liking what it sees coming in from the foreign DNA from the sperm, as it were. So it's quite extraordinary when you think about it, the fact that any of us are here, because, you know, the complexity of the immune side is extraordinary. But it hopefully should dispel any concerns or confusion that people have about how important the immune system actually is for pregnancy. So on that note, I'm going to get into some of the questions, because there's millions of them here. So again, apologies in advance to anybody. If we can't get to your question, we will do our best, but certainly I'm sure you'll be able to follow on either with Dr. Abraham or myself if you would like to follow up with a question. So I'm going to display the first one here. Let me see if I can get this one up, if it's responding. No, is that you seeing that there? Okay, it's not wanting to display the question. Let me go to the other box. Maybe I'm clicking the wrong one. Give me 2 seconds, guys. No. Okay, there seems to be a glitch with the question display at the moment. Hopefully Caroline can sort it out for us. In the meantime, I will read it out and hopefully you can follow along. It's not too long. This person writes, I had a failed euploid, day 5, grade A embryo. I transferred 6 days after a late night trigger. Progesterone was a high level, but only had, only had 98 hours of exposure. Should I insist on 7 days after late night trigger for next FET? I don't think you can see the question there. So
okay, yeah, I can.
Yeah.
So 3 concepts that we should talk about. Okay,
Yeah.
let's start out with the embryo. Okay,
Yeah.
so when we talk about embryo grade, okay, first of all, this was a euploid blastocyst. Okay, now blastocyst and day 5 embryo are not synonymous. Okay, blastocyst is a stage that a mature embryo reaches, sometimes on day 5, sometimes on day 6, and sometimes even later on day 7. Okay, now the quicker that it gets to that stage on day 5, the better. Okay, so a day 5 embryo is already telling us that there's good quality, grade A. That's top quality embryo. Usually we have a separate grade for the inner cell mass and another for the outer cells or the trophoblast. I'm just going to assume that it was a double A grade embryo. Okay.
Yeah, it doesn't say.
Now, in terms of quality doesn't mean that, it doesn't mean that a grade A embryo is going to be necessarily euploid. In this case, it was a euploid embryo, so we have a reason to believe that everything was fine with the embryo. Now, the transfer was 6 days after a late night trigger. Okay, so this is either a fresh embryo transfer or a transfer that was made with a natural modified cycle. Since it's euploid, I'm thinking it's going to be the latter. Okay. Now, when we think about how to calculate the
days
window, okay. So once you apply the trigger, okay, we are going to count 36 hours, and then after those 36 hours, we're going to add the other 5 days. Okay. So basically, let's say that you had a trigger injection on a Monday evening. Okay. Let's say Monday, 8 p.m. Right. So day 0 is going to be Wednesday, 8 a.m. Okay. And then we're going to count 5 days. 0, 1, 2, 3, 4, 5. Okay, so that's the appropriate way in which we calculate the embryo transfer. Okay? Now, what if it's a day 6 embryo? Doesn't matter. Again, it's a blastocyst. It doesn't mean that because it's a day 6 embryo, we need to prepare that your lining for an extra day. You would transfer it just as you would a day 5 embryo.
And in that person's case, I'm just thinking it's very upsetting, obviously, having an unsuccessful transfer of the euploid embryo. They're kind of focusing mainly on the progesterone and sort of the timing of, the day 6 or 7 afterwards. But would that really be what you'd be focusing on in terms of potential causal factors? I mean, for this person, if they haven't done so, maybe doing other investigations if they have another euploid embryo to transfer?
Well, that's kind of where we have to balance things out, because even a euploid grade A embryo won't attach 100% of the times. At least that's not what the evidence has shown us. So there's always a possibility that even when everything's tightly measured and everything seems fine, we could end up having a negative result. And that's not always a reason to either do any further studies or modify the whole treatment protocol. So that's a conversation that you should have with your doctor regarding the hours of exposure to progesterone. And other than that, see if there's any reason as to why you would go into a more in-depth analysis or not. If this is the first embryo transfer, it may not be a reason to have any further testing, but that's something that you can discuss with your care provider.
Definitely should be always individualized. We'll try then reading the next question. So this one says, hello, what is the role and the benefit of a trigger shot? For example, Ovitrel in a modified natural FET. Is there a higher chance of implantation success when using a trigger shot compared to a fully natural, non-medicated FET?
Okay, Katie wrote that question. So so when we use Ovitrel, it's especially because you mentioned the natural modified cycle. So there are two reasons why we would choose to use Ovitrel during an embryo transfer. In a modified natural cycle, the reason as to why we're using Ovitrel is because that growing follicle that we're following, we need that to ovulate so that the follicle starts producing progesterone, right? So that's why we would use Ovitrel, okay? Now, that's not the only reason why we would use Ovitrel. Also, some clinicians might decide to use Ovitrel for 3 days right after the embryo transfer, okay? This has two purposes: to kind of boost the amount of progesterone that you are producing, and also because the embryo naturally produces HCG. So it's a way to kind of triggering your lining into having a better receptivity for that embryo. So to answer your question, Ovitrel was used to induce ovulation so that your follicles started producing progesterone that is necessary for the endometrium's activation. But from your question, I don't fully understand if that's the only time if they used Ovitrel, or if they also used Ovitrel after the embryo transfer.
True. It's hard to tell for sure. But yeah, suffice to say, it would obviously depend on which scenario as to which would be most useful. So the next question here, a simple one. Hi, are hysteroscopies recommended even if the standard ultrasound is normal?
Yeah. So sometimes, and this is very frustrating, sometimes there are things that we might miss on the ultrasound scan, okay? And the reason for that is because the lining is not static, right? So our ability to see inside of the lining sometimes depends on the point of your cycle at which you're at. So if we suspect that there might be something going on, or if we had a few negative results, it is a good idea to do a hysteroscopy, because there might be something that we're missing on the 2D scan.
And this is kind of follow on. It's the same person actually asking the question, asking, would then a 3D hysteroscopy be enough to dig deeper after multiple normal ultrasounds? Because this person has had 3 recurrent implantation failures using egg donation or egg donor embryos, which is very tough.
Would a 3D hysteroscopy
be enough for sort of the doing the deep dive in terms of investigation? Really, I think is what she's asking.
Yeah. I understand that you mean a 3D ultrasound scan, or a regular hysteroscopy. So a 3D scan is a non-invasive way in which we can get a bit more information than we can from a 2D scan. And this is especially useful if what we're suspecting has anything to do with the cavity. Whether it's a normal shaped cavity, whether we're suspecting that we may have a T-shaped uterus, or whether we're suspecting that we have a anatomical malformation. Okay, in those cases, the 3D scan is a great way to assess this without having to use a hysteroscopy. For anything more subtle, it's going to be very hard to replace a hysteroscopy, in the sense that with a hysteroscopy, you're getting a first-hand view of the endometrial cavity.
Makes a big difference. And just to fly through some few more because we're running out of time very quickly. Simple one here. How do you recommend treating Asherman syndrome?
So Asherman syndrome has to be treated surgically through a hysteroscopy. Okay, it doesn't necessarily has to be a surgical hysteroscopy in the sense that it doesn't necessarily has to be under anesthesia, but that's going to depend on the amount of scar tissue that there might be.
It'll be super individualized with what's going on internally. So speak to your gynae and see what they say. An interesting question here, actually I haven't seen before. Are those TSH figures that we quoted for the ideal levels for pregnancy versus the average person, is that also for women 50 plus going through donor IVF?
Yes, in those cases, the set limit of 2.5 is going to be very similar.
Because whatever age you're at, you're still trying to get pregnant, you know. So it's,
But there are all other things that we're gonna look at. It's not just the TSH, right? So it's this TSH, T3, T4, and the thyroid antibodies that we kind of have to group together and then decide what we need to treat and what we don't need to treat.
Because very important for people, I know we didn't really have the time to go into it, but just to understand that you can still be in the literature euthyroid. In other words, your TSH can be under 2.5, but if you've got sneaky TPO or TG antibodies going on in the background, that can still impact odds of success. So yeah, getting a good thyroid workup makes a big difference. It's not just about the TSH exactly. And this person asks here, which is a pretty important question, have you seen unexplained recurrent implantation failure with large numbers of banked euploid embryos? How common is this?
Well, so not that common. Okay, so the reason why I'm saying that not that common is because recurrent implantation itself is not that common. There was a recent study that looked at doing 5 embryo transfers. I can't remember right now if they were 5 euploid or 5 blastocysts, but
I know the one you're talking about.
Yeah, but they found that 99 or 96% of patients achieve pregnancy after 5 transfers. So the paper cited something like recurrent implantation failure, mirage, or statistical anomaly, something like that. So yeah, it's really something that's not very common. And as I said, one of the most important factors is the embryo's genetic content. So again, with euploid embryos, that would be even less common.
Yeah, because it's been mostly accounted for. Not that it can't happen. I mean, I think, it's very easy for us, talking about stats and, the overall picture. But when someone's living it as an individual and they're going through hell, it kind of doesn't matter what the numbers are. It's your lived experience of it and how difficult it is going through unsuccessful euploid transfers. So to that person, if that's what they're going through, I would definitely say that, well, query things with your clinic, because the definition of insanity would be doing the same thing over and over again. If this keeps happening, there must be something going on. Because maybe, like you said earlier, once, okay, that could be just bad luck, because only 60 to 70% would implant. But if it's happening 2 or 3 times at euploids, I'd be asking some questions.
Yeah, that would be a great reason to do further studies into Definitely. Not the embryos itself, but to the actual lining to see what would be happening.
Yeah, no, there's loads there to investigate. And I'm just looking, there's a number of longer questions here. Apologies, but I'm just looking at the time, and I know we have to try to keep it some shape or form inside the reams of what we're meant to be covering. So if anyone who has sent in questions here, I can see the longer ones, would like to send them on to either myself or both of us, Dr. Abraham as well, at Clínica Tambre. I'm sure you'd be willing to respond or give some clarity. albeit within the remit of bearing in mind that, you know, I don't think any of us can give individualized specific advice when you're not necessarily a patient or client. So just be mindful of that too. But before we wind up, I'd love to hear a bit more about the clinic in Alicante. Anything you'd like to share about Clínica Tambre in general? As I know you've, you know, shed light on the reproductive immunology unit, and it seems like they're doing great things. So what's going on at the moment that people could benefit from the clinic?
Yeah, so just to give you a little, you know, some background about Tambre Clinic. Tambre Clinic is a clinic that has been around for over 45 years in Spain, and up to recently, the clinic was based in Madrid, and we've recently opened a new location, southeastern Spain, in the city of Alicante. We very recently opened our doors, and it's a clinic that, you know, aims at being able to provide fertility treatments for, you know, for patients in Spain, but also for patients that come from abroad. Okay, and we hope that, you know, this location is easier is of easy access to people that come from all around the world. And yeah, we're very excited about this new clinic, and very happy to be about to officially open.
Officially open, like it's only been weeks, because I think it's so important for any you know, Irish UK followers who I appreciate might have come to this webinar through my page. Very important to note that with travel abroad, it is not as scary as you might think it is, okay? And in vast majority of cases, I'm trying to actually think of those who have come back to me with complaints. That's not happening. They're coming back saying how great it was, the level of tech, the, you know, level of monitoring, how nuanced the protocols are, the level of care and follow-up. And I just think really important, if any of you watching aren't maybe receiving the level of due diligence that you feel you are wholly entitled to, that you do explore other clinics, because I can tell you there can be quite a big difference from what I've seen. And from what I've noted on the Clínica Tambre website, you guys seem to know what's what. So I was really pleased to see what was noted there. So thank you so much for sharing that. And from my end, of course, if anybody's not familiar with me, I'm Jessica Bourke, aka the Fertility Detective. So I've been doing this for 20 years, and I've been doing my best to tie the threads of information together for people so they understand what to do next, what's the best clinic consultant for their needs, as everything I do is all non-biased, evidence-based. So feel free to reach out if you're struggling and if you need any further information, because I think, as you probably agree, Dr. Abraham, the most important thing in this journey is that you realize you're not alone. And, you know, when you're talking, what is it, 1 in 6? So at any one time, there's about 186 million people in the world who are going through this. So that probably helps you to feel not so alone, and feel that you can reach out if you need support. You know, I think that's really important. So huge thank you to my IVF Answers and to the European Fertility Society, because that is why you are watching these webinars. They have arranged them. And I think it's a great service because you are getting all this information totally for free and getting access to information that can help you to make informed decisions about your next steps. So if there's any follow-up from this, as I said, you can check in with either myself or Dr. Abraham. But otherwise, feel free to submit your feedback on any further topics you'd like covered in the future, as I'm sure would be happy to oblige. Anything to add at your end, Dr. Abraham, before we sign off?
Glad to be here. It's been another excellent talk, and yeah, glad to be here.
Thank you so much for your time. Really appreciate it, as I'm sure everybody does too, with your wonderful answers. And I look forward to talking to you again in the near future.
Yeah.
Take care, guys. Great talking to you.
Bye.
Bye-bye.